Okay.
Hopefully I can make this work. I consulted with Ashley, who usually does these, to make sure I knew how to do the recordings. Uh, let's see, I need to probably share my screen. And I'm just running the data in right now just to feed it in. So that'll take just a little while. I should have started that a few more minutes ago. So we're going to be, going in there and looking at stuff that, let me see. Okay. That haven't really, we haven't really looked at before. I've looked at it just enough to make sure my code worked. But we're going to drill down and look at adults, adolescent kids, and so forth. So you guys will be as surprised as we are. I had to really resist the temptation to go look at the results. I just got to say, it wasn't easy for me. But the data accumulates at such a rate that it changes. I mean, I had looked at it earlier and even shared some of that with Scott Miller and posted some on our website, but it's different now. So from what I saw a couple weeks ago is not the same now because there's so much more data. Did anybody look at the interview that I think it was Cindy posted, Scott's interview earlier today?
No, missed it.
It was pretty good. It was good. Some of the things he talked about, we see different stuff in our data, and I don't want to spend too much time on that, but I think we'll comment on that. But our data looks different than some of the things he's talked about. So it's, who knows? Who knows what's what, really? I'm just at a kind of a high level. What are we measuring? I'm just going to editorialize briefly on this. My staff has certainly, heard this a lot because they, Ashley, who's going to be joining us, does the factor analysis routinely and looks at our items. There's all kinds of talk about, are we measuring well-being? Are we measuring symptoms? What are we measuring? Distress, well-being. The ORS measures, one thing, not symptoms, but well-being. My observation on that from analyzing a bunch of items is that we're making a distinction without a difference. If you drill down at an item level and do a factor analysis, and you have items that measure supposedly well-being, I feel like I can handle my problems, I'm satisfied with my relationships, I feel happy. And then you look at the item that is sort of the opposite symptom. I feel sad. I have conflict in my relationship. So whatever your reverse of that is, they all load on the same factor. It's all the same thing. You can call it well-being, you can call it stress, but in the end, when you look at items, it's amazing how much they correlate with each other. So if you say you're measuring depression, Well, that's great. Except that depression items correlate very highly with anxiety items, which correlate very highly with social conflict, loneliness. You know, everything correlates with loneliness, for gosh sakes. Uh, Functioning, daily functioning, these things all correlate very highly. So to talk about them as different um, constructs, as we would say, you know, in psychometrics, it's all one construct. You call it well-being, you can call it distress, and a lot of items load on that. So when we put together a questionnaire, it's a collection of items that load on this construct. And they may have different face validity, you know, it may look like, you know, I mean, we got depression, we got anxiety, we got it worded positively, we got it worded negatively. We have various social items, you know, different agencies will look at different things, or they have opinions that we should be measured more well-being and stress, what have you. And so the questionnaire has different mixes of items, but in the end, they all function very similarly because they are all loaded on a single factor. We call it global stress, but we might as well call it global well-being. Uh, you know, high scores indicate greater levels of stress. So that's what we're going to be looking at in these questionnaires, which are not just, they're different flavors of the same thing. So who else are we waiting on here? Let's see.
Ashley's joined. I don't think Talk has yet, but I don't know if he was able to make it today.
Well, he's, I talked to him a little while ago, and he does have, doing his papa thing with his little boy. And so he made the delay, you know, diaper or what have you, but he's pretty doing this. And I'm just reading in the data right now. I should have jumped on that a little bit earlier, but we'll be there shortly. Oh, it's there. Okay. So real quickly, just to sort of explain what I did, we went through and calculated all of the results based on current data. So, you know, whatever came in within the last 5 minutes, it's all there. We do adjust when we calculate effect size. I don't want to go too much into this, but we adjust for diagnosis. So here is the basically analysis covariance. Each diagnostic group has a different slope. And we adjust for that. So we have a variable we call the severity adjusted effect size. And it will show up here in, you know, we just call it effect size, but in reality it is a severity adjusted effect size. So it's taken into account different diagnoses. Also, was the questionnaire administered at the first session, or did it take a little while? Because you get a different result. It controls for differences in the questionnaires. So the questionnaire gives us, you know, pretty similar effect sizes. There's not a bias for using one questionnaire or another. It's as much as we can minimize that. Can everybody see my screen okay?
Yeah, I'm able to see it.
Okay, I'll take that to mean yes.
Yeah, you look great, Jim.
What's that?
You look great.
Yeah, okay, good. So anyway, we got it all in there. So let's take a quick pass at the start of it. And, well, let's look at our sample. So we've got 141,000 observations. Some of those we call time of corona is March 15th element of this year, and the rest is 2 years prior to that as a baseline. So what I want to do is just do some quick means and look at some differences in baseline and current variables. What I'm going to run here is means for a global stress assessment. Number one, that's your intake score. Your the first self-harm score, thoughts of self-harm or whatever. First substance abuse score. All the questionnaires, with the exception of maybe the children's questionnaires, have some substance abuse items. The first social score, which is going to be conflict, isolation, loneliness, is an item on a lot of these questionnaires. The change score is pre-post change. That's going to be less relevant right now because obviously they've had a lot more time prior to the corona period, so those are going to be different. Effect size is going to be different. Assessment numbers are going to be different. But we can look at the differences in these intake scores. Pre-corona and currently. And there we go. I can just walk down this and comment on it real quickly. There's not appear to be, much difference at all between the intake scores before and in corona. That's a very small difference. A self-harm is a little bit lower. I don't know if that's meaningful or not. We'll find out in a minute. Substance abuse is lower in the time of corona. Again, we'll see if that's significant or not. The social score is also lower. So in general, on these sub-skills, we're looking at the scores during the time of corona tend to be lower. Now this is combining adults, children, and adolescents, so we can drill down and look at that. But that's kind of at a high level what we're seeing. Certainly no sign that it's higher. Maybe some indication it's lower. But there may not be any statistical significance here. So this will tell us, I'm going to run a series of simple ANOVAs, which are simply going to look at the differences between time of corona and prior to that, and give us a quick readout on significance levels. So on the total intake GDS at the first session, there is a trend, but not significant. P is close to 0.1, but I wouldn't trust that. And the difference in the scores are not much. I mean, we got such large sample sizes that we can find significance when there's not much practical difference. On social, we are approaching an 0.5 level, which starts to get interesting. And I don't know what we'll see when we drill down. Is that across the board for adults and kids? Is that adults only? Is it coming from kids? What's going on here? But again, remember that the scores are lower, not higher. So I don't, start thinking about what to make of that. Okay, on self-harm, we are now significant at the 01 level, actually the 005 level. That starts to be pretty meaningful. And again, the time of corona score is lower than the baseline, the pre-time of corona. So I would not have predicted any of this. So, I don't know what it means. And then we have substance abuse, which again is significant, and it's lower. Reported less substance abuse. So, any preliminary thoughts on this, or should we keep going?
What's interesting to me, this is Chris Potter speaking.
Hey, Chris.
What's interesting to me is trying to sort out what social context there may be that could be affecting this, because of course, under lockdown, the biggest variable is that the individuals are locked down and there's less social exchange. I'm wondering, is there any way of toying out or any of those factors? Because I'm kind of curious. Of course, one of the things we've been hearing so much about is the increase in domestic violence with the seclusion and lockdown. So I'm wondering if there's a way of toying out any of those social variables out of this.
Now, we don't have it in the data. The items would be things like I feel lonely, I have conflict with friends and family. Ashley, you're on the call. Do you remember some of the items that tend to be on a lot of questionnaires, or Kyle?
Get into fights with family or friends. This one. I'll pull it up.
You gonna pull up the list of items here?
Yes.
You want to share your screen quickly? We could show the items.
Let me find it first, and then I'll let you know.
Okay. Well, anyway, you get the idea. I mean, the items are asking about stuff that we would think would be associated with increased conflict, maybe domestic violence, loneliness, certainly. But it doesn't seem to be showing up. If anything, it's going in the other direction. So I don't know. I don't know what it's due to. I'm totally surprised by this. But these are pretty decent sized samples. While she's looking for that, the next little bit of code we'll look at if there's any difference between video therapy and face-to-face. We've got a variable that started to track that somewhere around the 1st of April, or probably more like the middle of April. Kyle, do you recall when we got that variable in place?
I don't remember the exact date, but I would say somewhere around the 1st of April would be the better guess.
So what I did here is I looked at, was the last session coded as video or not? I don't entirely trust this data, because basically the forums had a place that said this is telemedicine. And if they leave it blank, then we default to it was face-to-face. I'm not sure that's accurate, but we didn't want to force a choice or whatever. We didn't want to make it too difficult. But it does give us something to look at here.
Okay, you can make me the presenter.
What's that?
You can make me the presenter.
Okay, let me run this little bit of code here, and then I'll make you the presenter. Okay, so if the we've only got 85 cases that were video therapy. Now, is that accurate or not? I don't know. It's probably an underestimate. But if you look at it, again, it's early on, but the effect size is significantly larger for video therapy than for face-to-face, apparently. I mean, it's 0.54 versus 0.73. We'll see if that's significant. Not really, 0.1. If the sample size were larger, it would become significant. On the other hand, if the sample size are larger, we probably get regression to the mean too. So I don't know. But it's interesting. This will sort of manifest itself as we go forward. The assessment number is a little higher for the video. They're maybe getting a little more therapy so far than the non-video. But that probably is not terribly meaningful. But I plugged it in, and we can see that neither the last video or the assessment number is predicting the effect size. Close, but but still 0.11, 0.12 p level. I wouldn't count on that holding up, in my experience. Rather than getting more significant with more data, you tend to regress to the mean. Could be wrong. Okay, Ashley, let me make you the presenter here for a moment. For a little while, let's see. How do I make you presenter?
You click on my name and then click on my name and then say make presenter.
Okay, okay, there we go. Click on your name. And
Okay, so right here.
I went ahead and made her presenter.
I don't know to make you the presenter yet. It's not. Oh, yes. Okay. Excellent.
So where my cursor is now is the subdomain. So once we get down here to social, these are all sorted together. And then to see what the item says, just scroll over visually to the left. And then usually the beginning of the questionnaire says in the last 2 weeks. So then ... Did you ask for help when you needed it? Feel like your child didn't want to be close to you? And you can kind of just read down through these. And I will scroll in a moment.
I notice on the child questionnaire, the social questions sometimes have more to do with how they're doing within the family, or like arguing with adults, things like that. That they're a little more behavioral maybe than with you.
That's the very one I was looking at.
What's that?
I agree. That was the very item I was looking at as you were speaking, arguing with adults. And I saw there were 4 very often there.
Yeah. While she's scrolling through, I don't want to be too distracted, but when we've coded them as being on the social scale, that's kind of a judgment call based on face validity. There is not a social factor. If we factor analyzed all this, it would all be global distress. So we just kind of broken it out based on our best judgment of, where it belongs. Okay, we spent a lot of time factor analyzing stuff. I can't find a factor for depression or a factor for anxiety or, any of that stuff. It all is the items correlate on this global underlying factor. On every questionnaire I've ever looked at.
And then we get down to risk. So that's the end of social.
Okay. Appreciate it, Ashley. How do I take back, make my screen?
You right click on yourself, your own name, and then you'll have an option to make presenter.
Right click.
Do you see your name?
I'll take care of it, Jeff. Okay, you should be presenter again. You will need to click the screen button again to share your screen, I think.
Thank you so much.
Yeah.
I'm glad you guys don't call me Boomer. Yeah, I appreciate you tolerating the no man's stuff. So let's drill down and look at the same analysis, but I'm going to break it out by adults and then kids, or self-report for kids, and then parent completed for kids. Here's a series of analysis for adults. Sure that worked, yeah. Now I got to make sure I'm looking at the right things. So there's the means for a time of corona. Global stress score is very similar. Self-harm is very similar. Substance abuse looks lower. And the first social score looks a little bit higher. But overall, those look pretty similar. Let's see if there's any significance there. So this is the intake score. P is 0.4. There's nothing. That's entirely random. On the social score, 0.22. That's random. 1 out of 5 chance you'd find that. On the self-harm, no difference. Again, 0.25. It's random. On the substance abuse score, we're at 0.0, we're below 0.01. So reported less substance abuse at intake. And that's pretty significant. I have no idea what that means, why that is. Again, it surprises me. Any comments or questions before I drill down and look at the other subgroups, kids and children? adolescents and children. All right, let's march on here. This is the youth's self-report questionnaire. Generally, this would be an adolescent. There's no hard and fast rule about when you use the self-report or the parent report. Obviously, you're more likely to get parent report with younger kids. But we do have some self-report for kids that go down to pretty young ages. It all kind of depends on what the clinic wants and, the particular kid. Perhaps where you let them use a self-report, you're asking the parent. Okay, well, it looks like our global distress score is lower, some. Self-harm is lower. Substance abuse is a little lower. I wouldn't think that meant much. Social is lower in time of corona. I would not have predicted any of this. Let's see what we get. Oh, you're kidding me. So that little bit of difference in the first assessment on global distress does show up as significant. Of course, these are big sample sizes, but it's lower and it's statistically significant at the O1 level. Social is lower and statistically significant at the 0001 level. Wow. Self-harm is lower, 05 level. P is 0.2, 0.3 there. And substance abuse, nothing there. Okay, I don't know about you guys, but that's surprising to me, how much lower these are. So let's run the same thing with the parent completed questionnaires. Anybody have a question or comments? Last little bit?
I have a question.
Yeah.
That is by which these the tools are filled out. I mean, I'm wondering, the thing that jumps out at me is milieu. Might there be a difference in scores based upon where the survey is completed, whether it's completed while the individual is at home for a video conference versus in the office? I'm just curious about that.
We can look at it, we can look at it for video. They would have had a text or an email sent to them or something saying, here's the link, fill it out. So you're right, that might be different. If it's not done, with an email or text, in the clinics, most of the clinics hand them a little tablet when they first walk in, and they fill it out then. It's all set up with their ID number, blah, blah, blah. In some clinics, the therapist may do that or hand it to them. And I don't know if that makes a difference. In some cases, the therapist is go into
So
submit it.
I would just pose that question.
Yeah.
Might there be a difference in self-report based upon milieu and where the person's completing it?
If it's video, I know that, we know that they were at home. But there, when we looked at the differences in scores, video and non-video, we can go back and look at that. There wasn't much difference.
Right.
So I don't know if there's that. Now, is there something about people seeking therapy during the time of Corona versus before? If anything, I would have thought that because it's a little more of a hassle, perhaps that we would have seen a higher level of distress. I don't know why we're seeing a lower level of distress. I mean, there are always unexplained variables that we can't capture. I sometimes call it the magic variable. There's always something out there that could explain it. You just don't know what it is.
Coronavirus.
Something, yeah. So here are the results for the parent completed. We've got a lot fewer of those than we did of the child self-completed. You can see, I think on the child, we had about 800, and here we got about 392. But interestingly, it's the same pattern. Intake score is lower. The global stress score is lower. The self-harm is lower. The first substance abuse, a little bit lower. The first social is lower. I don't know if now this is interesting. The effect size is pretty high, and yet we've only had, not that much time. Interesting. I didn't even look at that. I don't know what that means. I mean, we've got a lot of improvement in not a lot of time. You can see here that we got an average of 2.9 assessments prior to Corona and only 1.3 right now. And yet we got an effect size of 0.83. That's only 50 cases on the kids. I wouldn't trust that. So the intake score it's significant lower. The global stress is lower. First social is lower. That's significant. The first harm is lower, significant at the 0.5 level. And substance abuse, no difference. So let me come back here where I can see folks. So I don't know. I would not have predicted any of this, nor do I have at the moment a good rationale for why these scores in the time of Corona should be trending lower rather than the same. Any thoughts on this, folks? Help me out here. I'm having trouble even thinking up a good post hoc explanation, frankly. Well, you guys are a lot of help. Anybody want to toss out a hypothesis of why they seem to be trending lower rather than higher, or the same? Okay, I mean, it looks like enough of a pattern across them. Sorry, go ahead.
It's very interesting to me. I find whenever something doesn't show up as expected, that excites me because it brings out questions, and it's something to explore over time. But I find that, yeah, I'd ask that question: what factors might be contributing to this? I don't know. It's interesting. I still find it interesting.
I'm going to be curious now. Scott predicted in his interview earlier today that scores would be the same, but over time, as more problems showed up, there'd be a delayed reaction, and we'd see scores go up at some point in the future. Maybe. I don't know. I'm just stunned at the moment that they seem to be lower. And if it were on one of the variables with one of the populations, I tend to ignore it. But it seems to be across multiple variables and across the different populations and tests. So I'm going, well, that's a little harder to ignore. I don't know. Obviously, data keeps rolling in at a pretty steady rate. And we'll be able to run the same code again, a week later, and it'll look different. So who knows what we'll see in the future, and also how these cases turn out, because right now a lot of them are just getting their therapy started. So we'll see how they turn out. I'm particularly curious about the video and non-video to see if there's any difference there. My prediction there's not a difference, just because I always bet on the null hypothesis.
Right.
Anybody else got a question or a thought on this?
I think it's interesting, quite fascinating. I do think or suspect that there may be a bit of a delayed reaction insofar as levels of distress start to build up over time. I do think it's interesting. I think in Ireland, I suppose we're kind of triangulating some of this insofar as we have lots of statistics from the liquor stores. And as regards to alcohol use, that has gone way up over in Ireland as compared to what it usually is. Now, obviously, we haven't got this data to actually look at. Is that actually reflected within the counselling setting? But I do suspect, I suppose, a bit of a hunch really, that as time progresses, I do think we'll see, well, where I am at least, a little bit of more distress within people, or maybe that distress is not higher levels of severity, but actually more people presenting.
Yeah, that could be. By the way, Daryl, would you just introduce yourself? I've known you online a little bit. You're in Ireland, obviously.
Oh, so
you're
yeah. I'm in Ireland. I'm in Wicklow. I'm a counsellor. I'm from Ireland. I'm from Dublin, but I live in Wicklow at the moment.
And you've got, is it a consultant firm you've got, or it's something about outcomes?
Yeah. I'm a practitioner, and I had worked, I suppose, for a number of years in the substance abuse area, and I'm working in private practice now.
Okay, so, and you have a lovely family. Because I see you.
Thank you, Jeb.
So I'm glad you could join us. It's always nice to make a connection, beyond our usual folks in the U.S.
Likewise. I'm very happy. It's good to reach out and actually get to know people, including Chris. Me and Chris met online as well, so me and Chris are on Facebook together.
Likewise, yes, I agree that Facebook has brought an unusual consortium together. I like that.
Well, this has been great. I am still going to I confess to being totally surprised. I'm going to have to at some point I want to write this up, and I'm going to, but God, I can't even speculate on reasons why. There's clearly a kind of a expectational value that there should be at some point showing up is higher levels of distress, and I had that same expectation. Why is there a delayed reaction? I don't know. The if that's what it is, I would have bet any amount of money. Well, that people manage to take the initiative to go to therapy at a time where it's more difficult to go, perhaps, would have been showing more distress. That's what got them motivated to not less the stress than we normally see. I'm baffled.
Well, I think either you said or someone else has said earlier that it is very early, and in 3 months it's not much time for anything to hatch, really. So it'll be curious to see in another 3 months what happens.
I think we'll have a much better picture exactly in another 3 months, and we'll know a lot more. Plus, we can also easily break down the sort of time of corona into segments. So we can say, well, in the first 2 months or 3 months, this is what we saw, and then here's what we saw 3 months later. I mean, we can easily do that. So I'm going to be very curious.
Using a grief model, one might even suggest early on there's a bit of denial, and then later on you're going to see an increase or a crisis stage of distress, and then so forth and so forth. I don't know. I just still find it very interesting. I appreciate you doing this, Jeb.
Well, I love this stuff, and I'd rather do it with some other people give me input at this point, particularly since we're finding what didn't expect. If I found what everybody expected, I'm like, well, okay, that was easy. But this isn't. I like your comment on grief. This is just anecdotal, but one of the family members called me. They're all at home, and they got a 14-year-old girl at home, and she's withdrawn and reading all the time and kind of looking, whatever, and they're worried about her being that this could be long lasting, and they could get her out in the sunshine to brighten her up. And I'm thinking, God, the last thing you want to do with a teenager cooped up with her parents is try to force her to do something. But anyway,
a certain kind of hell.
That was the first thought I had. I said, good luck on that battle. I know this kid real well. She doesn't like to be told what to do. And she is really smart, and she will argue with me. But I talked to my daughter, who's she's a school, she's a clinical social worker, but worked in school settings for, some 8 years now. I mean, she's an experienced counselor. And she's working from home, but she's still dealing with all of this stuff. And she says she's getting lots of calls from parents worried about the kids' behaviors. One thing or another, and she keeps saying it's grief. That's okay. They're just grieving. It's not something we need to do something about, except, let them do it, as long as, And that's what I was thinking about my niece. She loves to read. If she wants to withdraw into a book from interacting with the family and everything else, let her do it. This is not necessarily a problem to me. So, again, I don't know. People are coping with stuff in their own ways.
Jeb, question is, do you have data, I'm not sure if you have covered it so far, on existing mental health difficulties and if that has been exacerbated further by COVID?
you mean how they were doing prior to this, if they were an existing patient prior to this, and then they went into this period?
Yes, yes. If the distress levels have been exacerbated.
I do have that data. I haven't looked at it that way. That's a little more complicated analysis to look at their change. Part of the problem is that people don't stay in therapy very long. I mean, most people are done in 5 sessions. To find people that were chugging along for 10 sessions and then Corona hit and see what happens next, it's an increasingly small sample. I'm going to have to wait a little bit and see. It's there. I can look at it. And I may noodle around with code. It's a good question. Take a look at that, see if there's anything in their sort of trajectory of improvement that suddenly changed.
Good question, Daryl, because I'm kind of curious. One of the things I've been reading is the reduction of no-show data when you do video conferencing, video sessions. Hence, perhaps there'll be a longer retention for a number of individuals, so the data in another 3 months might look very different. I'm just curious.
Yeah.
I'm just curious.
I'm betting on, I would bet on something like that. Certainly reduction of no-show. I mean, to drive into the therapist's office and sit in a waiting room and go see the therapist is a significant commitment of time, as opposed to doing it on the web. I know we've talked internally, that we're betting that video therapy becomes a big part of what gets done going forward now that people have gotten used to it.
I agree.
We'll see. I don't know. I just don't know. That's why we started tracking it, because we were thinking that, there's a good chance. We look at sort of the data we just looked at. There's some indication that they're getting a little more frequency of sessions, but it's also new that we got to let it play out. In another 3 months, we'll know a lot more. How they're doing. But I agree. I mean, it would seem to me that retention is easier, no shows are less. That's what I'd bet on.
Well, I really think the work that you're doing comparing video conferencing sessions versus in situ sessions is very valuable. And I hope that you can continue to look at that over time, because I'm assuming that there'll be more, especially in rural areas out here in Oregon, there may be more opportunity for continuity of care when you can use video.
Yes, we will look at it, because now that we've gone through the trouble, Kyle can speak to this. To add the variable to every single questionnaire we have, we aren't going back. that was a piece of work, and I give a shout out to Kyle here for pulling that off and doing it fairly quickly. We had to add the variable to the database, and then we had to add it to every single item. And
brilliant.
How to display it online and so forth. We'll track this from now going forward forever. And who knows what we'll find.
What do you think, Daryl?
In regards to, sorry, I missed the last piece.
I'm wondering, Daryl, what you might think about ongoing study of video treatment therapy and how that might impact things like show rates, outcomes, duration of session, that kind of thing.
Oh, wow, brilliant. I'm really, really interested in this. I think it is a fascinating area to study going forward. I actually had a conversation with a clinical psychologist recently who was suggesting that, anecdotal of course, but a lot of her clients with PTSD were actually favouring the online video consultations as opposed to the live sessions. I do think there's going to be a great opportunity to actually reach out and, I suppose, meet the needs of a wider cohort of people. I really do think that key here is going to be the preference accommodation, and those guys that actually like or enjoy doing it through a web-based format are going to be the guys that will really benefit from it, as opposed to, I guess we're in a position now where we're forced online, so those that don't have a preference for online therapy, maybe the guys who don't benefit from it fully. But it's really fascinating. I'm really, really interested to kind of see what happens here. I don't obviously have the answers, but it's a really exciting time, I think.
I'm real curious about this. If I had to bet, I don't know. I mean, young people are more used to digital connections and things like Facebook or FaceTime or whatever. They may take to it easier. We can speculate all we want. I just don't know. I would not bet against video therapy as being effective. I wouldn't bet against it. Whether it exceeds face-to-face, I don't know. That would be very interesting if it did. And again, question come up with an explanation for that one.
Well, then I would be interested to see insurance companies. I mean, there may be an incentive to provide more video in terms of cost also. So I think that may be a factor that could play in.
Yeah, I understand, and Ashley, you may weigh in because you're in closer touch with the different agencies, but I understand that at least for the time being, they're paying the same CPT amounts for video as face-to-face. So you're not taking any financial hit for doing video. How temporary that is, who knows? If they do pay at the same rate, suddenly setting up a practice of video therapy as opposed to one that's physically located suddenly becomes a very attractive option for some people. Well, we're coming up on the hour here. I appreciate everybody joining us. I'll probably do this again in a week or two. Let the data sort of percolate a little bit. I'll post out there if I'm going to do it again if anybody wants to join us. Because I'm going to be sort of watching this as we go forward. I'm sort of fascinated about it. If you think of any sort of ways to, again, I want to just babble on, but I am surprised that the level of stress generally seems to be lower. And I'm going to sort of, write this up and put it up on the website. But I sure wish I had some way to sort of talk about it. You always seem so much smarter when your data shows what everybody thinks it should show. Than when it shows something people don't expect. This is my observation. But if there's something wrong with our data, I can't figure out what it is. It seems to me to be pretty representative of psychotherapy. Okay, well, thank you all. I'm going to go ahead and end it. Ashley, do I end the meeting and then say convert to recording? Is that it? Hey there. Oh, okay. Oh, no, I don't. Let me look. Hang on. Ash, Ashley has lost her, Ashley and Talk have lost their audio connection. And she just told me that Talk had put something into the chat box. So I have to find the chat box. Yeah, yep, I see it. Uh, okay, so Talk says, do we know if there are supply issues with drug and alcohol because of the pandemic? Uh, well, good question. Uh, I I don't know. I mean, reportedly sales are up, but and I mean, I don't know about drugs, but other than here in Utah, our marijuana shops have remained open, so it's an essential service. Uh, only observation I'd make about alcohol, and I don't, but this is purely my own little liquor store, is because of social space, and it's a pain to get in. You're going to stand in line quite a while to get in, depending on when you go. And so my observation is once I was in there, I stocked up more than I might have because it was such a pain to go. Got more wine than I normally would have or whatever. But, you know, that was just me. I have no idea. Um, I mean, is it possible, let me just toss this out, is it at all possible that people staying at home together is actually helpful rather than as stressful as we imagine? They're kind of all in this together. I could see there might be less, again, speculating, less substance abuse if you're sitting there with the family the whole time rather than headed out for a bar after work or whatever. Maybe. Is there any possibility that actually all of this family or time at home is actually in some ways helpful in the sense that we're all in this together and plus we're not dealing with other stressors that might be out there? I don't know. Well, okay, I'm going to go ahead and end this. Ashley, you just hang on in case I have an issue here. Okay, well, everybody, I appreciate you being on this call. I'll keep you informed. I'll try to get some kind of a write-up out there, but if we do it again, I'll give you guys a heads up. Again, appreciate you joining us. Okay, Ashley, here goes.
Thank you, Jeb.
Yeah.
Thanks, Jeb.
So long.
Thanks, Jim.
Okay, Ashley, end meeting for all. Do you want the end of meeting for everyone? Yes.